All right, next slide, please. This is just information regarding the AAFP credit system. Next slide, please. And these are the core competencies that the grand rounds will address. Next slide, please. And then here's a brief introduction by Dr. Shi.
Here we go. So, hi, it's my great pleasure to introduce Dr. Melanie Stone, who's the assistant professor in our own family medicine department. So she's director for community engagement learning at the Cheever Center for Medical Humanities and Ethics. The innovative CEL program promotes student and faculty engagement with community organizations in conducting service projects which benefit medically underserved populations in Texas. So she's also an adjunct faculty at UT School of Public Health, San Antonio Regional Campus. Dr. Stone is passionate about public health and enjoys integrating a public health focus into an academic health science center. Her expertise in health literacy and her expertise is in health literacy, and she helps bring health literacy awareness, knowledge, and skills to the healthcare professional workforce. Dr. Stone is the co-director of Health Confianza, a multi-level community health literacy program where she developed a novel organizational health literacy pledge program. She serves on the governing council and is the chair of the Policy and Advocacy Committee of the Texas Public Health Association and is co-collection editor of the WAMC MedEd Portal's Community Engagement Collection and serves on the International Health Literacy Association Standing Committee of Practice Standards. She's an alumni of Leadership San Antonio and Leadership Texas. Without further ado, we'll have the pleasure of having Dr. Stone tell us about organizational health literacy. So I have the luxury of working with Dr. Stone in the Health Confianza project. So I'm really excited to hear any updates and successes and stories in this program. Thank you.
Thank you so much, Dr. Shi, and thank you for the invitation to present Grand Rounds today. So thank you for that great introduction. I just wanted to comment that I have been working in the field of, so I've had the pleasure of directing our community engaged learning program here at the Health Science Center since 2008. Before that, I was with University Health System, and that's when I developed my interest in health literacy. So this was back in the mid-2000s. And the term health literacy was just being talked about. So my experience with health literacy in those early days really was just bringing awareness to the community about what health literacy is. It then evolved to my training healthcare professionals and future healthcare professionals in health literacy practices. I've had the opportunity to develop curriculum for community health workers. I co-lead our health literacy practice called Health Confianza, which we're going to talk about more later. And my latest work has really been delving into this area of organizational health literacy. So that's what I would like to talk to you all about today. And I do want to acknowledge our Health Confianza team, which has been just incredible. It's been wonderful working with them over the past several years. Our work with Health Confianza did begin with a grant. So I just wanted to acknowledge that grant source from the U.S. Department of Health and Human Services. So today we're going to be first just kind of doing a review of health literacy, making sure everybody is on the same page about this concept and its effects on people in the community. We're going to focus on organizational health literacy concepts in particular, and we will discuss strategies for creating a health literate primary care practice. And then finally, we'll end with a case model where I'm going to talk to you more about what Health Confianza has been doing in the area of organizational health literacy. So I always like to begin with this quote, nothing is so simple that it can't be misunderstood. I think it's a good reminder for all of us who are trying to relate complex information. Even basic information can be not necessarily understood well. And so it's a communication issue. It's something that we should always be keeping in mind. So I want to begin today with reflecting on a documented scenario. So this is a real scenario that was documented several years ago, where a 2-year-old was diagnosed with an inner ear infection, prescribed an antibiotic. Her mother understood that her daughter should take this medication twice a day. She looked at the label and decided that it doesn't say how to take the medicine. So she made her best guess using the information that she understood, and she fills a teaspoon and pours the antibiotic into her daughter's ear, obviously causing worse effects with that happening. And so I just wanted to hear from the group. If you're comfortable unmuting yourself, I would love to engage with you that way, or you can feel free to put your comments in chat. Is this a realistic situation for you all? Is this similar to patient encounters that you may have had? If someone wants to kind of chime in here. Don't be shy.
I guess I'll volunteer. I think it's a little bit maybe more extreme of what we would see, but I don't think it's unthinkable. I mean, patients, you never know what they will um, have some sort of common sense how to take instructions or ask questions. I know, I think it's not unthinkable to have that happen in real life.
Yeah. You may have heard of the case where a patient is supposed to be taking an asthma inhaler and it's not working for her. And then when they find out how she's actually taking it, she's spraying it on her neck like a perfume because she didn't understand the instructions. Someone in the chat is saying about a pulse oximeter. They thought it was a thermometer. So yeah, that could be a mistake too. So the reason I like this particular scenario is because it shows something that happens to a lot of us, right? So we have some understanding that the mother wasn't completely off. She understood that this was what the medication was for. She understood it was to help her daughter. She needed to take it twice a day for her ear infection. She just didn't understand one part of it, and that could have been the fault of the doctor explaining it to her or the pharmacist maybe not explaining and making assumptions that she, would know what to do with it. And so just that slight misunderstanding can have really bad, devastating effects. So I'm going to have you now do a little bit more practice. I should have warned you, this was an engaging session. This is a paragraph that we're going to all read aloud together. You're going to notice some of the words are written backwards. But we're going to go ahead and just read it out loud. So I want people to unmute so that I know when you've stopped reading it. Okay, so let's go ahead and begin. I'll get you started. The National Action Plan for Health Literacy.
Needs to engage
organizations, professionals, policymakers,
Policymakers.
communities, individuals, and families in a linked
yep.
multi-sector effort.
Effort to improve health literacy. Plan is based on the principles that
everyone has the right to health information that helps them make informed decisions and health services.
I mean, you're being too good there. Me is good at reading backwards. Okay, I'm going to stop you here. I won't prolong the pain, but okay, just think you're reading this, and then I'm going to ask you questions about what you read. So, what is one principle the National Action Plan is based on? Can anyone answer that?
everyone has the right to health information that helps them make informed decisions.
Okay, thank you, Dr. Bergeron. So I like this exercise. Hopefully you all got a sense of what it's like to have low reading skills, right? You can decipher the words. You eventually were able to, even if they were written backwards, you were able to do that. However, you may not comprehend what it's saying because you're concentrating so hard on just reading the words. Are you going to now be able to take action on this if that's something that you were asked to do? Now imagine you were asked to read, comprehend, and apply something like this in the context of just having received some upsetting health news. Perhaps you received a diabetes diagnosis, or you learned that your child's tumor has come back. Now imagine having to read all of that, comprehend it with that mindset of not being in the right state of mind. So this is what a lot of our patients are having to deal with. So let's level set on what health literacy is. This is the long-standing Institute of Medicine definition that you may be familiar with. It's from around the time that I got involved with health literacy, 2004. The degree to which individuals have the capacity to obtain, process, understand basic information and services needed to make appropriate health decisions. So that's what we've been talking about here. People are trying to take this information and then do something with it. But the demand is really intense as we keep evolving in the world and with healthcare. We have to deal with medical technology, which is a good thing, but it also makes things complex. Your treatments become more complex. We're living in a digital age. That wasn't the case, 20, 30 years ago. We have social media that's providing us information and misinformation or disinformation. We have now AI that is affecting everything. And then there's our political climate that we all live in, which can influence healthcare. So take a look at this photo. These are some excuse me, just get some water. These are some incredibly brave people, right, who are getting just the perfect shot. When I saw that, I was like, wow, those are some brave people. Well, the reality is that rock is only a few feet above the ground. So all that's required here is the proper perspective. So we have to remember that when we're reading or viewing material on the internet, sometimes the truth is a lot different than what it appears when you first see this picture. Now, I fell for this one because I'm a cheese lover. So I saw this on social media and I was like, okay, what do I need to be doing with my cheese? Well, guess who the experts are? So again, that's just a fun one, but there's a lot of information, there's a lot of misinformation that we are bombarded with that we have to decipher in order to do our everyday health decision making. So let's review some basic concepts about health literacy. Health literacy is not the same as literacy because it also includes skills in numeracy and communication and the ability to act on different types of health information. A key point is that health literacy is a patient safety issue and has a direct link to poor health outcomes. So specifically, low health literacy is associated with worse ability to understand and follow medical advice, worse health outcomes. It's associated with increased hospitalizations and emergency care and decreased use of preventive services like screenings and immunizations. So not surprising then, low health literacy has been estimated to cost the U.S. economy between 106 billion and 236 billion annually in healthcare expenditures. And that is now kind of an old number, so I'm sure it's even greater than that. Health literacy is modifiable at different levels, the individual level, interpersonal, organizational, community, and macro. And I'm going to discuss this multi-level approach with you with our Health Confianza program a little bit later. And then, while there are some robust evaluations of health literacy interventions, there needs to be more progress in this area. Right now, the county health rankings and roadmaps does rank health literacy interventions as having some evidence of having expected benefit for the population. And those benefits are increased health related knowledge and adherence to treatment. So there is some baseline for this, but we need to continue working to evaluate health literacy. So, though low limited health literacy has been shown to be associated with worse health outcomes, those causal pathways are not entirely known. And this area of research is tough because limited health literacy is strongly associated with other socioeconomic indicators, including educational attainment, race, ethnicity, and age. So these authors reviewed the evidence in the literature to produce this initial conceptual model. We chose clearly that health literacy impacts many aspects of behavior that influence health outcomes. So work is beginning in this area to start fleshing that model out. Let's have a pop quiz. How many Americans do you believe struggle with health literacy? You can put in the chat or you can just shout out whether it's A, B, C, or D. So far, I think I've seen all the letters. Some C's, some B's, B's, C's. All right, I've only seen one correct answer so far, and that is D, 90%. So that was based on an older national health literacy survey. This survey found that 9 out of 10 adults have difficulty using everyday health information. Now, that doesn't mean that a person's going to consistently have trouble. Maybe they're having situational problems like we talked about earlier. It might come and go, or there might be areas that you have higher health literacy in. But the truth of the matter is that the majority of our Americans in our country are having struggles with using this health information. So what does that look like? Well, this is an example. If you are proficient in your health literacy, you can do something like calculate your share of health insurance costs. If you have dealt with health insurance in any way, you understand that is a very high level skill. Intermediate would be determining what time a person can take their prescribed medication. So you would hope that most people could do that, but really that's only 53%. To be able to answer simple questions or even circle the date of your appointment, that is what is basic and below basic. And so you can see that more than a third of our US population is falling in that basic or below basic. So we need to get people into that proficient category. So again, this data is a little bit older, but the issues with health literacy have only gotten more complex over the years. It remains a serious problem. So what does that mean in practice? Well, these are all common areas where people may run into trouble if you have low health literacy. When I was doing the pledge program, which I'm going to talk about in a minute, some of the practitioners would tell me, well, getting directions to the clinic is actually a rather large barrier. So not to put our practice on the spot, but with our UT primary care practice, we have a clinic in the Hill Country, which means it's up I-10, where there's a lot of traffic, a lot of construction. To get to it, if you don't take the right exit that's not, displayed very well, you're going to get off on the wrong track, and then you have to turn around, which could take a while. What happens if you can't understand the directions to a clinic, or once you're there to navigate your way in those hallways to find where to go? That's going to delay your appointment. And then that means you have less time with your provider who has to stay on schedule. Less time means less ability to educate and understand and use teach back, one of our health literacy practices. So it has a cascading effect where you might think, well, that's something very simple. Well, if you address those simple challenges, you're actually going to affect people's health literacy in the long run. These are some other areas we have, communication, which we're going to talk more about, informed consent. Do your patients really understand what they are consenting to? I will just disclose I recently had a surgery, and did I read word for word all those consent forms? Absolutely not, which is probably how most people are. So, if we're not reading them, no one's explaining it to us, are we really giving consent? The biggest area, of course, is with medications. So people who are in that basic or below basic, they're going to be 5 times more likely to misinterpret their prescriptions than those who have adequate skills, which, as you all know, can be a deadly consequence. Health literacy is also a health equity issue. There are certain groups that are more at risk for having low health literacy. So specifically, low or limited health literacy is higher among older adults, racial and minority groups, people with lower incomes, those with less than a high school education, and people who are medically underserved. So the traditional view of health literacy that focuses on the individual patient's capability to understand and use healthcare is evolving to a systems perspective. So Healthy People 2030, our nation's public health agenda that gets set each decade, has now updated the definition of personal health literacy from that IOM definition that I presented to you earlier to now it's being separated out into personal health literacy and organizational health literacy. So personal health literacy, it emphasizes people's ability to use health information, not just understand it. And it focuses on the ability to make well-informed decisions rather than appropriate ones. So there was some fine-tuning that was done to that definition. And then this idea of organizational health literacy, this brings a public health perspective by emphasizing the role of environmental and structural factors that very much affect patient outcomes and population health. It acknowledges that our organizations who help people understand health information, whether that's a clinical setting or social services or a nonprofit, have a responsibility to make their services easier to access, understand, and use by their clients. So for the rest of the presentation, we are going to focus on the concept of organizational health literacy, which I'll now call it OHL. So how can organizations reduce demands on and improve support for their patients and families? Here's another conceptual framework. This is a newer one, and this presents 4 domains in which to intervene. So the areas that as an organization you can focus on are organizational structure, policy, and leadership, communication, ease of navigation, so that's that wayfinding, and then patient engagement and self-management support. So let's focus on some strategies for how you create a health literate practices and how you operationalize OHL. So in 2013, Howard Koh and his colleagues published this model for a systems approach that recognizes that improving health outcomes relies on patients' full engagement in prevention, decision-making, and self-management activities. They discuss health literacy being an organizational value infused into all aspects of planning and operations, including self-management support, delivery system design, and helping patients access community resources. I think a lot of you are probably familiar with this. It's also known as a universal precautions approach. And so for today's presentation, I'm going to distill this model into these 3 areas that your clinical practice can focus on to improve health literacy. First one is the clinical environment. So this universal precautions approach means treating all patients as if they are at risk of not understanding health information. When healthcare providers use this approach, they acknowledge that professionals can't accurately identify who understands and who doesn't, that health literacy is situational. Even individuals with proficient health literacy, as we said earlier, may also have trouble understanding health information at times, like when they're sick or frightened or in pain. And so everyone benefits from clear, actionable information. Let's watch this short video of Mrs. Walker, who discusses her struggles with reading and strives to hide it from everyone. And Catherine, if you're still on, I'm not sure if I clicked the button to hear it. So if you're not hearing it, let me know and I will stop the Zoom and share.
One of the things that most of us learn how to do is to hide it exceptionally well, because it's a terrible embarrassment, you know, and the shame that goes with it is devastating. So the last thing in the world you want an intelligent doctor to know that you have any kind of problems other than the ones that you're there to see them about.
So the point here is patients with low health literacy look like any other patients. They may be pretty good at pretending that they understand. Mrs. Walker, as you see, she's very articulate, and just by listening to her, you would never know she has low health literacy. So some red flags that you might see in your practice are people incompletely or inaccurately completing their forms, frequently missing appointments, not adhering to the medication regimen that you gave them, not following through on orders for tests or referrals. A lot of times you'll hear patients say, oh, I forgot my glasses, so I can't read this. And if you stop and think about it, how many people can drive or navigate without their glasses? And so, there's these red flags that you can be looking for. And then if you want to learn how to make your practice have this system-wide universal precautions approach, this is a great toolkit from the AHRQ. I recommend that you download it. It has evidence-based guidance to help healthcare providers make health information easier to understand and act on. And so it provides some great resources for you. Let's hear from Mrs. Walker again, this time talking about the shame a person feels when they struggle to read.
The embarrassment, the shame, I mean, it's just overwhelming. It really is. It paralyzes your thoughts completely to think that you may say something or something is put before you to read and you can't read it. I mean, you live with that on a daily basis.
So a goal should be creating a shame-free environment in your practice. And one thing you can do is making sure that you use plain language. And something we tell our students is that doesn't mean you're not going to use the technical term. It's probably good for your patient to hear you say the technical term, but then also explain it with plain language so that they can associate that now. Making sure you have interpreters. Do you have interpreters on hand? Do you offer assistance in helping people complete their forms? Use TeachBack to confirm understanding, simplifying your signs, using symbols rather than words, using color. Color is actually a really good tool. Encouraging questions. If you make it the norm that the patient should have asked questions, that will make them feel more comfortable doing so. Ask Me 3 is a good campaign that you could always put the signage in your office that helps the patient be encouraged to ask things like, what is my problem? What do I need to do? Why is it important for me to do this? And then always making sure your patients know how to get that follow-up help. We also want to work on workforce training. So when we get our healthcare professionals adopting some of these health literate communication skills at the time of their training, we hope that that's going to carry over into residency and their future practice. And so these are some tips for improving communication skills, showing empathy, being an active listener, asking open-ended questions. So this is always a key point that we train our students on. Don't say, do you understand at the end of your appointment, because that just shuts people down. If you ask them that, they're most likely going to nod or say yes, even if they don't understand, because they don't want to feel embarrassed to tell you no. It's hard to say no. They could be intimidated. And so they'll just say yes, even though they leave your office not understanding. Rather, what you should say is, what questions do you have for me? And that sets the norm that you should have questions, and it also gives them the opportunity to go ahead and ask that. Chunking and checking is making sure that you're not overloading them with too much information. You're putting it into bite-sized packaging for them. We talked about using plain language, making sure that they have family and friends. It's so important. I have friends who work in hospitals as nurses, and When the patient doesn't have anybody with them, their outcomes are just so much worse than if they have an advocate there helping them. Using stories is a really powerful tool. As adult learners, we make a lot of analogies. And so if healthcare is not a subject matter you're really comfortable with, but you are really familiar with how cars work and you're an auto mechanic, having that analogy relate to whatever is being described to you, if you can put it into terms that make sense to you, it's really helpful. Of course, understanding cultural context and then using the teach back method. And this is someone in our medical school has this on, or at least they used to have it on their door. And I just thought that was a really good quote as well, supposedly from Albert Einstein. All right, so there are a large number of recommended health literacy and clear communication practices, things that we've been talking about, such as avoiding jargon, effective questioning, using interpreters. But the number one ranked practice is teach back. So that is what we've prioritized in teaching to our students here at the Health Science Center. It's a technique for providers to ensure that they have explained medical information clearly by asking the patient to repeat back in their own words what they understand or what action they will take. This is a photo of us having our first year medical students practice teach back in their little groups of 3. And then COVID-19, of course, influenced a lot of our communication practices. And so our Health Confianza team we decided that we would focus on these 6 particular communication skills during the time of the pandemic, when there was a lot of miscommunication, misunderstanding, a lot of unknowns, right? And so we decided about talking about setting the tone. It was important, active listening, using plain language, acknowledging different perspectives, bridging respectfully, and then using teach back. I'm going to focus on just 2 of these skills because I think they're ones that are less common in our communications training. And that really became important during this new world that we're living in. And so acknowledging perspective. So with something like COVID-19, people are going to have strong feelings about their beliefs. And you always want to make sure you validate that person's feelings or perspectives. It doesn't mean that you have to agree with them. And just by validating them doesn't mean that you have to agree with, maybe some information that's not correct. But that patient needs to feel heard. If they don't feel like you're listening to them, then they're not going to pay attention to the rest of what you're going to say to them. Also reminding yourself that a lot of how they feel and how they think is based on their culture. That influences a lot of this. And then these are some phrases that you can use to acknowledge their perspective. Well, I can see why you feel that way, or, I'm sorry you were impacted by the virus. So that makes them feel heard. They know that you're listening to them. The key here is avoiding adding that 3-letter word, B-U-T, to your response. If you say, I can see why you feel that way, but blah, 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 now you have just invalidated their feelings and their perspective. You can still accomplish your goal by, instead of saying, but what's another 3-letter word that you can say?
And
I can see why you feel that way, and here is what we're going to do, blah, blah, blah. And so now you haven't invalidated with them, but now you have an opportunity to give them the information that they need. So good job. And then this is a similar concept, but respectful bridging is a way for you to move away from a conversation that the patient is having with you, where they're describing misinformation. And you need to pivot from what is untrue to what you want them to actually remember. So these are some statements you can use. Well, I don't have an answer to that question. What I do know is, and so you're not spending time anymore on the the incorrect information, and now you're focused on what you want them to actually know. So these are just transition statements to help you accomplish that. And then the last practice point is collaboration. And so these are different levels of collaboration that you should be thinking about in your practice. So, of course, shared decision making. I know you all have had training on that, but it's so important for their patients and the healthcare providers to make decisions together. And so I won't say too much more about that one, but that is an important concept. And then we think about collaborating with the workforce. We have done a lot of work with community health workers as a member of the healthcare team that can connect people to healthcare and community resources. And it really, I think that's the movement of the future with healthcare. I know all of you are likely working with community health workers. And then with the organizations, and I think this area of community partnerships and organizations is an area that we could do more in. So these are our social services, public safety, literacy groups. They're all essential to having a health literate system. And so partnerships between healthcare providers and community organizations can improve access to the resources and skills that people need to manage their health effectively. You don't have to have all the answers in your particular practice. This is a group effort, and it's an opportunity to have those linkages to your furthering the healthcare of your patient when they are no longer in your clinical practice. And so it takes some effort to develop those partnerships, but you have resources to do so. And then, of course, the final largest level of collaboration is changing our system level, so policy and advocacy. All right, so let's focus now on organizational health literacy practices. And this is the first national call to action that stipulated the role of organizations. It was back in 2010, the U.S. Department of Health and Human Services had a national action plan, and it was based on these two core principles that all people have the right to health information that helps them make informed decisions, and that health services should be delivered in ways that are easy to understand and that improve health, longevity, and quality of life. So this action plan really focuses on a linked multi-sector effort to improve health literacy, and it has 7 strategies outlined. Just for example, one of the strategies is to promote changes in the healthcare system that improve health information, communication, informed decision-making, and access to health services. And then this call was then followed by an Institute of Medicine roundtable a couple of years later that provided a description of what constitutes a health literate organization. I won't go through these 10 attributes with you, but if you kind of scan them, you'll see it has to do with leadership. It has to do with training your staff. It has to do with the way that you design your systems and your materials. And so these are still in place. These are the 10 attributes that people are trying to achieve for an organization to become health literate. And so most of our OHL change studies focus on traditional health clinical settings like hospitals, clinics, healthcare systems. But there is a growing movement to recognize a community health literacy model. This one was put forth by the University of Maryland School of Public Health, and it emphasizes community-wide partnerships and where and how people get their information, as well as the level of difficulty associated with each. So community-based organizations, however, they may not even be aware of the construct of health literacy. So a link may need to be made between health literacy constructs and then the terminology that they're more familiar with, such as access to and equitable care. And this lack of attention on community-based organizations is actually a practice gap in the field of OHL, and it's an area that we focus on for Health Confianza. So I've been talking a lot about it. Now it's time to go into describing it a little bit more. And Dr. Shi, how are we doing on time? How much time do I have left?
We have about 15, 20 minutes,
Okay,
up to
perfect.
20 minutes.
Great. And I will leave time for questions at the end. So as background, it's fortunate that the federal government has begun recognizing the role of community-based health organizations in addressing health literacy. In 2021, the U.S. Department of Health and Human Services issued a grant award to San Antonio Metropolitan Health District, our public health department here in San Antonio, to fund health literacy initiatives related to COVID-19 vaccination and other mitigation practices. So Metro Health then partnered with UT San Antonio and our institution, UT Health San Antonio, to design, implement, and evaluate a multi-level health literacy program that we named Health Confianza, which is intentionally bilingual. The 2-year funded period was very successful. We reached over 15,000 impacts, and we wanted to continue this great effort. It's now housed at my center, where I am co-principal investigator with my colleague, Dr. Jason Rosenfeld. And so the goal of Health Confianza is to improve health literacy and increase the public's trust in health affirming messages with a focus on communities in San Antonio experiencing the worst health inequities. This map shows the 22 zip codes we focused on during our grant period. And these were areas based that were selected due to COVID death rates, COVID vaccination rates, the social vulnerability index, and some other indicators. You'll see it's all segregated here on the south, southwest, southeast parts of our city and county. We decided to focus, it's a multi-level approach, so we decided to focus on the community level and then the healthcare providers and then organizations. And so this is just a snapshot of our activities so you can see the comprehensive nature of our program. So this was a lot, and it kind of shows you how we focused on the community level, the provider training level, and then our organizational level. And so we're going to focus today on just the organizational level, which is what we call the Pledge Program. So this we knew from our experience with COVID-19 that many people in our community did not necessarily use or even trust traditional healthcare settings like clinics for their basic health information and services. Rather, they were turning to their trusted community-based organizations like community centers, churches, food banks, who they already had a relationship and were assisting them with food and financial other social service needs. So they decided that would be a good place to also get their COVID information and then later their vaccines. So this gave us our novel focus. We knew we had to target these community-based organizations if we wanted to actually improve health literacy and ultimately increase health equity in our community, because these organizations were playing that role, but were they being equipped to actually handle how to communicate about something as complex as COVID? And were they equipped to provide that basic health education and health literacy communication? So we decided during this grant period that we wanted organizations in our city to take a pledge to improve health literacy. The idea being that if enough organizations in the city make this effort, it would create meaningful impact. And we couldn't find any organized health literacy pledge programs when we researched it. I thought for sure there would be something out there, but there wasn't. And so we created our own, and it was a voluntary application process. We had funding to accept 10 organizations. And each organization would then identify 3 to 5 staff members who would be participating in the program. They were supposed to represent different levels of the organization. So they could be an on-the-ground health educator, they could be a manager, they could be a director, they could be someone from HR, they could be someone from IT, all different aspects of that organization where it may be relevant for making some organizational health literacy changes. And it was a certificate program that consisted of conducting a baseline needs assessment to identify areas of improvement at their organization. Once they made that once they conducted that assessment, then they participated in an 8-month learning collaborative where they learned about OHL, how to create OHL plans that address changes to policies and practices based on that needs assessment. So based on the areas of identified needs. And then the ultimate goal was to improve the ability of their clients to access, understand, and use their health services more effectively. So these are the 10 organizations that were accepted. So for folks here in San Antonio, you may recognize some of these organizations. They include 3 clinical, including our UT Health San Antonio Primary Care Center, which I want to point out because we are talking about primary care today. We also had 7 non-traditional health organizations, including community centers, housing programs. We had an HIV support group, and we had Texas A&M, a very large public university. We don't have time to go into the details of this data collection, but we did have a robust plan for evaluation, and we are currently working on publishing these results. We actually just had two articles published in the past month that talk about some of this evaluation effort. So I'm going to tell you a little bit about the assessment tool that we used. It's something called the HLE2, which stands for Health Literacy Environment of Hospitals and Health Centers. It's 2 because this is 2.0. They've updated their original one. It was developed by Dr. Rima Rudd at Harvard and her colleagues, and it analyzes 5 areas of an organization: their policies, their practices, their navigation, their culture and language, and communication, which covers print materials, forms, websites, and patient portals. So I contacted the authors when we decided to use this tool to ask them, well, has it ever been used outside of a clinical setting? And they said no, so as far as they know. So this is the first known time that the tool was used by non-traditional health organizations. So part of our effort was to see, does it work? Is this a good tool to use for those community-based organizations? And I'll tell you now that the answer is yes. I won't keep you hanging on that, and we'll talk about why it's yes. But after they conducted their HLE2, I met with each organization to determine from their results 3 short-term and 3 long-term actions. So these were actions that they found that they could do better in, that they needed to work on, and that they would then develop into their OHL plan. And this is an example from one of our organizations, so you can see the types of areas. They all ended up being very similar. A lot of it had to do with the concept of health literacy training of their staff, making it part of orientation, reviewing their materials for plain language, developing policies, and especially with their strategic plans. And so across the board, these were very similar. And then, so like I said, they would then bring these actions to the Learning Collaborative, which we ended up modeling after the Institute for Healthcare Improvement's Breakthrough Series. If you're familiar with that, that works on quality improvement initiatives. And for the didactics, we brought in some national health literacy experts to discuss OHL and how to make organizational changes, and who also served as resource mentors to help the organizations throughout the process, develop those OHL plans and really think about how they can turn it into actionable policies and practices. So in between our monthly sessions were our action periods where the teams would go back, get some buy-in from their organizations. That's specifically why we had those short-term actions, so people could see immediate changes taking place at the organization, and then continue working on their long-term goals. We decided to use the CDC template called Making Health Literacy Real, which you can see, this is what it looks like, for creating their OHL plans. And so in this structure, it first describes the issues that the organizations are seeing with their patients and clients. So you kind of have to identify what are your issues that you're seeing. And then you set a vision statement about how you want your organization to look. And then you set 3 goals. And so this is page 1, but there's 2 more pages. So each page has its own goal, it has an objective. And then how will you achieve that? What are your actionable steps and who's going to do them? And so for the analysis purposes, we ended up grouping all 3 of these together as an action plan. We performed a thematic analysis of the OHL plans and a 6-month survey to assess their progress on implementing those plans. And that now we're at the process of collecting the second HLA2 assessment. So they had their baseline, and then they are now completing the same assessment, the HLA2 again, 2 years after they did their first one, to see if their results are going to be different. These are some of the findings that I found from doing this analysis. I'm going to go ahead and share these because I think they're important takeaways for any practice, clinical or non-clinical, community-based, anyone who's trying to implement OHL change. So across the board, policies were one of the worst scored areas of the HLA2. Remember, there was those 5 areas. Policies was always their worst scored area. However, it didn't translate necessarily into priority actions. And so my best guess at that is that they needed more support. It's hard to write policy. It's hard to know how to write and create and implement policy. And so when we have our next round, which thankfully we have some funding to offer this again, and we are going to focus more on specifically giving them that kind of support. So we found that leadership is high, and so the leadership support is high, but more work needs to be done on building the staff awareness and support. Some of the organizations were quite large. They had a small team of up to 5 people doing this work, and we need to help them translate that to across the wider organization. And then we also need to provide more support in marketing their participation in this program. So we created some digital emblems that they could use. We created some signage, but on our part, we need to make sure that our community of San Antonio better understands what this pledge program means and what it means for an organization to actually go through this process. And so once we do that, I think there's going to be more client awareness and support. And then, not surprisingly, time is one of the biggest barriers to doing this work. Not a big surprise there. So we did find that both the clinical and non-clinical are able to successfully complete the HLA2. They're able to plan for OHL policy and practice changes. No one dropped out of this program, and so they did stay engaged, which is, I think, really important. Based on some of their qualitative responses, we found that the plans that they created have increased health literacy awareness, promoted integration of health literacy principles into daily practices, created health literacy champions, upskilled staff, and improved responsiveness to patients and clients. One of the team leads said this quote, which I'll read to you, because I think it summarizes kind of how the perspective was, especially with the non-clinical organizations who were involved. Although we have not rolled it out to all staff, we are in the process, and I feel like it will become part of our culture. Even though they may not recognize it as specifically health literacy, they will be doing what they need to do. All of the organizations believe that their future HLA2 will show improvement, which indicates increased self-efficacy. And so far, we've had 3 out of those 10 complete their second HLA2. And those improvements are linked to their OHL plans. There was a direct connection, but there was also general improvement all around. So even if their plan wasn't focusing, let's say, on the wayfinding, they still showed improvement across the board in the 5 areas. And then At the beginning, when we were pitching this program, especially to the non-clinical organizations whose main purpose is not to provide healthcare, they were in the beginning days a little hesitant about whether this really was the right fit for them. That changed after this going through the program. They no longer believe that. And in fact, one of our organizations got a marketing person involved, and that marketing person was like, well, our organization does a lot. I think this doesn't really, make sense. She joined the team, and then afterwards she's like, oh my gosh, these principles are relevant to all areas of what we do in our organization, and like very much now sees the linkage. So those are the stories I think that illustrate the success of the program. I did want to point out, as I said earlier, that the UT Health Primary Care Center did participate, and Dr. Cancino, the executive director of the center, said that the program provided the motivation and tools necessary for one of their faculty members who has an interest in making organizational level changes in how we think about health literacy to make a significant impact on our primary care center operations and our strategic planning process. My understanding is this is the largest primary care practice in San Antonio. So if they see benefits to this program, I think that says a lot. And then just in conclusion, the Pledge program has shown to be a unique model that has the potential to encourage transformational systems improvement for both types of organizations, clinical and community-based, discovering and adopting health literacy changes. And our belief is that it's going to lead to increased equitable understanding and use of services by our population, which is what we hope. So during the time of this grant period, we had a local TV station, KSAT, highlight the Pledge program. So it's just a couple of minutes clip, and so I wanted to go ahead and play that for you. Let's see if we can get that to work.
From hard hats to steel-toed boots, Grainger's got your safety needs covered.
The COVID-19 pandemic revealed a lot about our healthcare system, including the deep inequities in minority communities. 3 big local entities got together to change how and where many of those communities get their health information. Courtney Friedman tells us about the pledge that 10 non-health organizations are now making.
Historical health inequities in San Antonio's minority communities persist today.
Marginalized people out there, such as people of color, women, overweight people, who just don't trust going to a hospital because they don't know how they're going to be treated.
Irvinell Walters is one of the many people who get their information from the places they trust: churches, community centers, food banks, housing programs. So the challenge is making sure those places have accurate health information.
Little has been done to address organizations in the communities.
Melanie Stone is part of a team changing that. UT Health San Antonio, Metro Health, and UTSA started a nonprofit last year called Health Confianza, aimed at expanding health literacy in our community. One of those strategies is asking organizations to take the health literacy pledge.
I'm here at one of the Alamo Community Group's 10 affordable housing locations. They took this health pledge, and they'll be holding health events in rooms just like this one.
They identify areas that they need to work on, and that could be things like making sure their materials are written in plain language, making sure they have good signs for navigating through their organization, providing language interpreter services.
So if, say, a parent is giving medicine to their sick child, they need to be able to understand the directions. Offering instructions is part of an 8-month training for these organizations. A lot of work that people like Walters don't take lightly.
And I'm grateful to know that I'm not going to be overlooked.
Courtney Friedman, KSAT 12 News.
Keep up to date with all of San Antonio's top news, weather, and so much more by clicking the like and subscribe buttons below. And once again, thanks for watching KSAT.
I just had a few more slides showing some resources, but I think we may be out of time, Dr. Shi. So I wanted to see if I had time to show that or not.
Do you want to do a conclusion take-home message? Maybe we have time for that.
Yeah, so I was going to actually share, or if you could put on our website, maybe our website here. So we've developed some resources.
Sorry, we were not seeing your slides anymore.
Yeah, let me go ahead and share it again. Yeah, didn't go to the right spot, so sorry.
It's okay.
So I just wanted to leave you with some resources that. Yeah, sorry, I didn't have